Hi everyone, I'm Denis Nash, and in this session I'm going to talk about outcomes in implementation science, considerations, and examples. The learning objectives are to gain insights into how and why to choose implementation outcomes for your research, to appreciate the relationship between implementation outcomes and a conceptual framework, and also to appreciate how implementation outcomes are measured. I'm going to work through some of this stuff after just going over a little bit of general background, using an example of some research that we've been conducting in New York City in the HIV care coordination program, and specifically in relation to that, how our implementation science research evolved, and talk about a recent study that is actually ongoing right now, with specific attention to the implementation science outcomes, the measurement of those outcomes, and the data sources that we are using to gather them. So some of this may be repeated background, and if so, I apologize, but I just want to remind everyone that implementation outcomes conceptually and implementation research are distinct from service and health outcomes. The implementation outcomes are really the direct effects that we expect to influence through deliberate and purposive actions to implement new treatments, practices, and services. They help us understand about whether or not the implementation activities that we are focused on are succeeding or failing. They're more proximal indicators of the implementation processes, and there are important intermediate outcomes in relation to these other more downstream outcomes that we're also interested in, like the service outcomes, the clinical outcomes in patients and clients, and the population health outcomes that get at public health impact. Implementation outcomes are important because they help us understand the hows and whys regarding the effectiveness of interventions, and the success or failure of implementation strategies in the real world. So, we don't want to just know if an intervention worked, or a strategy worked or didn't work. We want to know also why it worked, how it could work better, or why it didn't work. Is it because the intervention is not effective, or is it because the intervention or the strategy was not implemented as intended? And again, this may be review for some of you, but we think about implementation outcomes in implementation science as distinct from some of the service outcomes and client outcomes. And by now, I think some of these outcomes like acceptability and adoption are familiar to many of you. And some definitions here. I'm not going to go through all of these, but just wanted you to have them in your video here, if you wanted to dwell on them. But these also are things that you've probably covered before, and also giving you a sense of some readings that you might want to look into for further detail. But when we choose implementation outcomes, there are lots of considerations that help us make the decisions, right? First and foremost is, what is the implementation science research question? And that really should be the key driver of what implementation outcomes you choose to look at. But what may limit your ability to look at all the ones you want to look at is what data sources are available for you to get them. You might be focusing on features of the implementation strategy and the level of implementation. So some implementation outcomes might be collected at the provider level, some at the site level. Other important considerations relate to the implementation science conceptual framework that you're using. So you will, and we'll see an example of this, you will want to map your implementation outcomes to specific components and constructs in your implementation science conceptual framework. And then there are, of course, considerations that are specific to your study. And I'm showing here an example of one of our studies where we did go through the process of mapping specific outcomes to specific aims in our research, the data source, and then went through the process of mapping out the data elements that we would use to construct these various outcomes. So here's an example of the conceptual framework for the PROMIS study, and we're going to come back to what the PROMIS study is in a minute. But you can see how we really began to map some of the conceptual frameworks to some of the specific study outcomes. We talked about how the intervention itself was really informed by implementation science intervention theory that informed the design of the intervention. Then we also used frameworks like REAIM and CFER to inform the study design. And finally, our outcomes were mapped to both implementation outcomes and intervention outcomes related to service outcomes and clinical outcomes. And we'll come back to this. So the example I want to cover is that PROMIS study. It stands for Program Refinements to Optimize Model Impact and Scalability Based on Evidence. And it really is a study about assessing the effectiveness and implementation of a revised service model compared to an earlier version of the model of HIV care coordination. And this is a model that is focused on patients in the US, in the Ryan White HIV care program, that have historically had barriers to ideal and optimal outcomes like sustained viral suppression. And it aims to coordinate a number of aspects of care and services for them in the hopes that it can help support them to better achieve outcomes like sustained viral suppression. The study, and I'll talk a little bit about the evolution of how it came to be, began first by evaluating the effectiveness of the original care coordination model. And in the process of evaluating the effectiveness of that model, we learned quite a bit about what worked and what didn't work, its effectiveness, and maybe more importantly, a lot of information about how we might improve the model so that it could potentially have more impact going forward. And that led us to the PROMIS study. And I'll talk about how we got there in a minute. But it basically was comparing a revised version of the model that was informed through practice-driven research and comparing the outcomes in that revised model to the original model. How did this come to be? Well, in the original care coordination model, we compared outcomes in the care coordination clients to those that are very similar patients that did not receive HIV care coordination. And what we saw is that if we looked at viral suppression at 12 months after enrollment into the program, those that were in the care coordination program had those that were newly diagnosed and enrolling, and those that were not newly diagnosed but didn't have viral suppression at enrollment, had significantly better outcomes than those who were not in care coordination. And so you can see the relative risks here: about 15% better viral suppression rates by 12 months for newly diagnosed patients, and about 30% better viral suppression for people who enrolled and didn't have any evidence of viral suppression at the time of enrollment in care. It didn't really do so well overall, maybe an 11% improvement. You can see that most of that improvement was due to what we were seeing in these two groups of patients. Those that had sort of inconsistent viral suppression coming up to program enrollment, and those that had consistent suppression really did not benefit so much from the program. More importantly here, I guess, is the even though the care coordination program did seem to improve outcomes, it wasn't necessarily getting this group of patients to a more optimal level of viral suppression. Only 42.5% of patients were virally suppressed by 12 months and after enrollment in the program. And obviously, it would be important to get viral suppression rates to be much higher than that. And so the program seems to work, but it also seems that there's room for improvement, especially in some patients. We also looked at the outcome of durable viral suppression. So looking out beyond 12 months, 13 to 36 months after enrollment. And here you can see, again, in that group with no evidence of viral suppression, this was where we really saw the main effect. It was about a 16% improvement over usual care. But again, only 21% of the clients had achieved durable viral suppression, which is, very strict definition of all viral loads less than 200 copies over the course of follow-up. Again, not optimal, and it suggests that the care coordination program, had modest effectiveness, but is needing some improvements. And so this was the CHORDS study. This was the initial evaluation of the effectiveness of HIV care coordination in Ryan White in New York City. And we concluded that, as I described, there remains significant room for improvement. One thing we also noticed that this is not necessarily a question of access. I didn't show these data, but most of the cohort achieved viral suppression at least once during follow-up. However, the sustained viral suppression remained quite low, and it suggests that it was not ART access that was driving poor viral suppression, but rather adherence. And so this gave us some clues about how the intervention might be modified to improve its impact. Um, I just want to also give a little bit of background about the care coordination client populations. They are in New York City some of the most vulnerable people living with HIV. Many barriers, such as unstable housing, lower mental health functioning, substance use. At least 50% of the care coordination population has at least one of these psychosocial barriers. And so these findings we took away that it really underscored a need for sustained and maybe more intensive adherence support in the vulnerable population with multiple barriers, but that also had high ART access and uptake. And that there could be some strategic changes to the care coordination program to increase its potential for impact. And the New York City Health Department, who implements the care coordination program, took some of these data and findings, as well as conversations with providers and stakeholders in the care coordination program, to make some refinements to it. And so I'm showing here some of the different refinements that were made to the care coordination program. They've added things like more assessment on the ability of clients to self-manage their HIV, the use of video chat tools, the use of immediate ART initiation. These are program components that were included or optional as part of program implementation. The eligibility criteria were changed. For example, there was no need to make people who had evidence of sustained viral suppression eligible for the program. We really wanted to see it focused on people that had the most need, people who were newly diagnosed, and people who were did not have evidence of viral suppression. Those were the groups for whom the impact of care coordination appeared to be greatest. The payment structure was changed so that there would be more of a fee for service model as opposed to a per client capitation sort of rate. And you can see here the kinds of things that we expected these changes to have an effect on. Some relate to uptake of the intervention by the provider, some relate to fidelity to the intervention, some relate to client engagement, some we expected to improve intervention effectiveness, and some we expected to improve population reach and impact. Also, I should have mentioned too that there were some very rigid, what providers and clients viewed as very rigid program tracks. Clients had to remain in some very intensive service models initially before they could graduate to lesser intensive models, and there were very clear restrictions on how soon and when they could move out of those, and it was viewed as very rigid by the providers and clients. And so this was something that was removed in response to what we learned, in the hopes that there would be greater uptake and fidelity to the model, given the strong feelings that many providers and clients had about it. So this reflects the way that the intervention was evolved in response to some of this early research. And the idea of the PROMISE study is that these course corrections would be expected to improve a number of things that could be classified as implementation outcomes: program uptake, fidelity, engagement, and some actual clinical and public health outcomes like the effectiveness and reach and impact. So overall, these course corrections were designed to better realize the goal of extending the benefits of the current treatments to those whose care needs have really gone unmet in other programs and in prior iterations of the program. So I want to take you through the aims of the PROMISE study, and then we can get into where we how we have selected the implementation outcomes, how we measure them, and things like that. So the aim of the PROMISE study, aims 1 and 2, were really about estimating the effectiveness of the revised program compared to the original program on timely viral suppression for aim 1, and we used a stepped wedge design to evaluate the impact of the program on that early viral suppression outcome. And then because the program implementation was happening in 9-month intervals, we needed to use observational methods to look at the longer term outcomes at 12 at 12 to 36 months. But this is a study that focuses on 17 clinics or clinical sites or care coordination program sites that all have been implementing the original care coordination model. And the idea is that half of them would be randomized to be early implementers of the new model. And 9 months later, the other half would begin implementation of the revised model. And that is why we could really only use experimental methods to look at short-term outcomes. And we're using observational methods to look at the longer-term outcomes. You can get a sense of some of our design features here for aims 1 and 2. But aim 3 is really where the implementation part comes in. The first 2 aims are focused on effectiveness. Aim 3 is really about identifying attributes and drivers of provider and client engagement in the intervention. And also we include a discrete choice experiment to look at provider and client preferences so that it can inform, again, future course corrections to evolving the intervention to have even greater uptake and impact down the line. We're anticipating that this is not going to be the last time that the program is going to need to be tweaked in response to the need to have even greater uptake and impact. But for this aim, it was really a mixed methods approach to look at factors that may be shaping the implementation of the revised care coordination intervention and preferences for the model attributes. So we focused in, of all the 17 sites, we focused in on a few ones that were more veteran implementers that have been implementing the original care coordination program for quite some time, but had switched to the revised model. And then there were also 3 new sites that were not involved in aims 1 and 2, but they were just new partners that are starting to implement care coordination for the first time with the revised model. And this would give us a range of partners to begin to gather information on implementation related issues. And the data collection is happening at the provider and partner agencies. The discrete choice experiments are something that are focused both on providers of the services as well as the clients who are receiving them. And where we're getting most of the implementation outcome data are coming from the qualitative interviews that we have planned with 25 providers and 30 clients over the course of the study. And again, these findings are also meant to inform how the care coordination intervention may evolve even further with time. So coming back to the conceptual framework, we used 2 conceptual frameworks, implementation science conceptual frameworks with the PROMISE study. The first is REAIM and the second is the CFIR. And I just want to talk a little bit about those before we get into the implementation outcomes, but they are, of course, closely related. Why the REAIM framework, first of all? Well, the REAIM framework attends to the essential program elements with the goal of improving sustainable adoption and implementation of effective, generalizable, and evidence-based interventions. It facilitates the examination of intervention effectiveness alongside the implementation processes, which is what we're doing in the PROMISE study, and it provides predefined measures of constructs like reach, effectiveness, adoption, implementation, and maintenance. These are all key implementation outcomes that we're concerned with. It's also well suited to assess how this revised care coordination program components might be implemented to yield results and to devise implementation strategies that might boost effectiveness going forward. And another thing is that REAIM is really designed for use across multiple settings. So we're working in many different care service delivery sites in the care coordination program, and they're all implementing the same intervention. So the REAIM is a good fit for the PROMISE study environment. And then also, why are we working with the CFR implementation science framework? Well, this is something, CFR has some things that we're interested in from an implementation science perspective that the REAIM framework doesn't provide, and that includes how things like context shapes the implementation of an intervention by providers and health systems. And you're probably also familiar by now some of the major domains of the CFR framework, such as the interventions, construct, the outer setting, inner setting, individuals involved, in processes. Some of these are not as represented in the REAIM. And there is some overlap between the two frameworks, right? Where the REAIM and CFR constructs overlap. We use the REAIM to construct more quantitative measures, and we use the CFR to construct complementary qualitative measures. And both frameworks do promote a detailed specification of the care coordination program components. So here are the key implementation outcomes that we are using that mapped directly to the conceptual framework. So for REAIM, we're looking at reach of the intervention in the priority populations that are engaged in HIV services at the sites that deliver the care coordination intervention. We have the ability to look at the entire universe of clients there who may be eligible, and therefore we can look at reach. We're looking at the effectiveness of the care coordination intervention to achieve its clinical endpoints, the adoption of these revised care coordination elements across both the sites and the client pools within the sites. So remember, we are starting with a group of sites that have been implementing the original care coordination intervention for quite some time. And then we can look at the extent and the rate at which these new revised elements are being adopted as part of our implementation outcomes. The implementation of key care coordination processes, including the active ingredients of the interventions, can be assessed directly, and I'll talk a little bit about data sources in a minute. And the maintenance of longer term outcomes, such as durable viral suppression, is something that we're able to look at. So these are how we're sort of mapping our implementation outcomes to the REAIM framework. And the CFR program allows us to test IS theory embedded in a particular program element. So for example, the reimbursement model that I mentioned, or the provider preferences that we'll be assessing in the care coordination, in the discrete choice experiment, we can assess how that may influence the implementation decisions of specific sites or specific providers. So the measurement of the IS outcomes in our conceptual frameworks can be supported by both quantitative and qualitative data collection, including mixed methods. We're lucky to have in the care coordination program a number of data sources that are really conducive to collecting implementation data. And these include the fact that provider reporting is required in order for providers to be reimbursed. So they have to report on their service delivery activities. And this creates an opportunity to gather good information on implementation outcomes. There's something called eShare, which is the electronic system for HIV/AIDS reporting and evaluation that the health department has developed and deployed, that's used at all Ryan White funded providers, not just care coordination providers. And so this is something that can be used to gather information because it captures longitudinal client level data on all the kinds of things that we're interested in for implementation, like when people enrolled in the program, demographics, their eligibility for the intervention, the care coordination intervention, ART status, adherence support, and other assessment dates, and receipt of specific services and the dates associated with those, such as directly observed therapy. And so the eShare data is what we'll be using to ascertain the program and implementation outcomes, including the ones I showed on the prior slide, re-aim constructs, fidelity to our model standards for the timeliness and periodicity and the type, mode, and quality of services that are delivered in relation to a particular client or client pool. There's also routine organizational site assessments that can be used to assess things like the workflows and staffing, staffing ratios, staffing cadres, and mix, to assess referral mechanisms that are in place and staff coordination. This is another useful thing for a mixed methods approach to understanding implementation processes. And the semi-structured interviews, of course, will be really valuable for us to elicit provider and client perspectives and input on barriers and enablers to successful implementation of our key program components and delivery approaches. For that, we'll be interviewing about 4 to 6 clients per site with semi-structured interviews, and also about 24 care coordination program staff that are implementing the revised care coordination program model. So that's how we're measuring the data sources that we're using to construct the implementation outcomes for the PROMISE study. So I hope that's a helpful example. And just to sort of recap some of the outcomes in implementation science, implementation science does include a focus on both implementation outcomes and health outcomes, but the implementation outcomes are particularly important, and they are fundamental to implementation science research. We choose these outcomes by considering a number of factors. First and foremost are the implementation science research question that you're asking, and then what's available to you in order to construct those implementation outcomes, the features of the implementation strategy that you'll be implementing, and the level of implementation. Is it a provider level intervention, or a site level intervention, or a community level intervention? Then you'll be choosing to match the implementation activities, a conceptual framework, at least one. Usually it's one, but as we saw in this example, we chose 2 for a couple of different reasons. And then you'll be wanting to map as much as possible the implementation outcomes to the constructs in the conceptual framework that are relevant and important for your implementation science research question. And then, of course, you have other specific study and context considerations. It's important to remember that implementation outcomes should measure the actual targets of the implementation strategies to deliver the intervention. So not things that are influenced by the intervention as well as other potential things. Those may be important, but we need to think about exactly what you expect to influence through implementation. And these things are essential implementation outcomes. So, and they should be explicitly considered or pre-specified. And without these, it's really difficult to understand the central questions of implementation science, the how and why of the effects of implementation or the lack of effects of implementation. We always want to be sure that we can say something about why there was no effect of the intervention on health outcomes, or why was there only a modest effect of the intervention on health outcomes. I want to acknowledge the team and our study participants on both the CHORDS and the PROMISE studies at the New York City Health Department and at CUNY and at the Care Coordination Service program delivery sites, and also our funders. And I'll just close with a couple of readings here that might be useful in our toolkit. I really hope that the example that we covered today is useful to you as you go through the training program. Thanks so much.